So, when we talk about alcohol related liver disease, we're not just talking about one single thing. It's actually a spectrum, a progression. It can creep up on you, moving from something you can completely fix to damage that's, well, permanent. And that's the key, right? The early stages, totally reversible, but you have to know what's going on to catch it. So, let's break down exactly how this all happens. Okay, so before we can really get into the damage, we need a starting point, a baseline. And this is it. A perfectly healthy liver doing all the hundreds of things it's supposed to do, no problem. This is where we begin. All right, now take a look at this. This is stage 1. We call it fatty liver or steatosis. You can see the change already. But look, the most important word here is reversible. This is so crucial. At this stage, we can turn this around. The damage is not permanent yet. And then there's this. This is the end of the line. Cirrhosis. The liver is scarred up, bumpy, and the damage, it's done. It's permanent. The journey from that last slide to this one, well, that's the whole story we need to understand. So that begs the big question, right? What happens in between? How does a liver go from that reversible fatty state all the way to irreversible cirrhosis? That's the journey we're going to map out right now. All right, let's look at this spectrum of damage from that initial steatosis all the way to cirrhosis. Okay, so there are really 3 main stages to this whole process. First up, you've got fatty liver, or steatosis. This is basically just fat building up inside the liver cells. The tricky part, it's usually totally asymptomatic, so you don't even know it's happening. But, and this is the good news, it's completely reversible if you stop drinking. Now, if the drinking continues, things can escalate to alcoholic hepatitis. The name says it all. Hepatitis means inflammation. The liver cells are getting actively injured. This is when patients might actually start to feel sick. Jaundice, a fever, a liver that's tender and enlarged. And finally, if things keep going, you hit cirrhosis. This is the end stage. The liver is just full of scar tissue, and that fibrosis messes up its entire structure and ability to function, leading to all sorts of severe complications. Okay, we've got the stages down. But what is alcohol literally doing to the liver cells to cause all this chaos? Let's zoom in and look at the cellular story. So it all kicks off with how your body metabolizes alcohol. Ethanol gets converted into a really nasty compound called acetaldehyde. It's super toxic. At the same time, this whole process cranks up the levels of a molecule called NADH. And here's where it gets interesting. All that extra NADH basically tells the liver, hey, stop burning fat and start making more of it. And boom, you've got fatty liver, stage 1. But it doesn't stop there. That toxic acetaldehyde is also directly damaging proteins, causing inflammation, and creating a ton of oxidative stress. It's just a full-on assault on the liver cells. And when this happens over and over, it flips a switch on these things called stellate cells. They get activated and start pumping out collagen, which is basically scar tissue. That scarring, that's the fibrosis that leads to cirrhosis. It's a really destructive cascade. Okay, we've seen the how. Now let's zoom back out and talk about the who. Who is most at risk, and how do we actually diagnose this in a patient? So obviously, the biggest risk factor is how much and how long someone has been drinking heavily. But here's the thing, and it's a really important clinical point. Not everyone who drinks a lot gets severe liver disease. There are other pieces to the puzzle. For example, women are generally more susceptible because of differences in metabolism. Malnutrition also plays a huge role. And if someone already has something like hepatitis C, it's like throwing gasoline on a fire. The damage happens way faster. When it comes to diagnosis, the lab work is absolutely key. Yeah, you'll see things like GGT and bilirubin go up, and the INR will be prolonged, which just tells you the liver isn't making clotting factors like it should. But here is the classic high-yield, gotta know it for the exam finding, the AST to ALT ratio. In almost every other kind of liver disease, ALT is higher than AST, but with alcohol, it flips. If you see an AST that's more than double the ALT, that is a massive clue that you're dealing with alcohol-related liver disease. So, once you suspect it, you need to figure out how severe it is. This isn't just for curiosity's sake. It's what tells us what to do next. And for that, we use a couple of key scoring systems. The 2 big ones you need to know are Maddrey's DF and the MELD score. And it's super important to remember they're used for different things. Think of Maddrey's DF as your tool for acute alcoholic hepatitis. If that score is over 32, it's a red flag for severe disease, and it tells you, hey, this patient might need steroids. The MELD score is different. It's a much broader predictor of mortality in anyone with end-stage liver disease. It's what we use to figure out who's the sickest and who needs a liver transplant the most.
Okay, so we've diagnosed it, we've staged it. Now, what do we actually do? Let's walk through the management plan.
The game plan here is pretty straightforward, and it's a hierarchy. Step 1, and honestly, steps 2 and 3 as well, is absolute abstinence. Seriously, this is the single most important thing a patient can do. In those early stages, it can literally reverse the disease. Step 2, nutrition. These patients are almost always malnourished, so you have to be aggressive with high-calorie, high-protein diets. Step 3 is medication, but only in specific cases. Remember that MADRE score over 32? That's when we bring in steroids, like prednisolone, to cool down the inflammation. After that, we're really just managing the nasty complications of cirrhosis, ascites, varices, you name it. And for those with end-stage disease, the only definitive cure is a liver transplant. All right, that was a ton of info. Let's boil it all down. Quick, rapid-fire review of the absolute must-know high-yield facts for your exams and for the wards.
That classic lab signature, AST to ALT ratio greater than 2 to 1. Burn it into your brain.
Remember, stage 1, fatty liver, is totally reversible if you stop the alcohol. That is the critical window to intervene. But once you get to cirrhosis, that's it. It's irreversible. Our whole goal is to stop people from ever getting to this stage. If you were to look at a liver biopsy under a microscope, you'd see these things called Mallory bodies. They're just telltale clumps of damaged proteins inside the liver cells. And the inflammation in alcoholic hepatitis is unique. It's not lymphocytes. It's neutrophils that rush in. Another super high yield point to remember. And really, this all brings us back to this central challenge, doesn't it? We know the early damage can be undone. We know who's at risk. So the question I want to leave you with is this. How can we, you and I, and the entire healthcare system get better at finding these at-risk patients and stepping in before it's too late? Because figuring that out, well, that's how we're really going to save lives.